Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary. For the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the diseases of epididymis. Cysts of epididymis. A cyst of epididymis is filled with a crystal clear fluid. It is a commonly occurring condition. It is formed due to cystic degeneration of the appendix of the epididymis, also called pedunculated hydatid of Margagni, or the cystic degeneration of the appendix of the testis, sessile hydatid of Margagni, or the cystic degeneration of the vasa varis, or the cystic degeneration of the paradidymis, and is the most likely cause. Clinical features. These are found in the middle age and due to congenital origin and are usually bilateral. These are dense and consists of aggregation of a number of small cysts which on careful palpation feel like a bunch of tiny grapes. Cysts of the epididymis are situated behind the body of the testis. Translucency give an appearance of Chinese lantern. Treatment. Aspiration may not be of help if giving trouble, which may be rare. They must be excised. Cysts of appendages of testis. These are separate clinical entity. These form a small globular swelling at the superior pole of the testis. It is usually unilateral and when pedunculated liable to undergo axial rotation. Treatment. The treatment of choice is removal by ligation and severance of its pedicule. Spermatocele. It is a unilocular retention cyst derived from some portion of the sperm conducting mechanism of the epididymis. Clinical features. The spermatocele is always situated in the head of the epididymis and is therefore above and behind the body of the testis, filled with the fluid resembling barley water and containing spermatozoa. The swelling is softer than other cysts occurring within the scrotum but is translucent. Spermatocele are usually small and non-obstructive. Rarely they are large and attract notice. Treatment. Small spermatoceles can be ignored. Large ones is causing symptoms can be aspirated or excised through a scrotal incision. The thin covering of the cyst are carefully peeled off layer by layer and our residual attachments are ligated and divided. Acute epididymo-orchitis. Usually infection remains confined to epididymis and is called epididymitis. When the infection spreads to body of testis, the condition is called epididymo-orchitis. When the inflammation is situated in the body of testis, it is called orchitis. The infection reaches the epididymis through the lumen of the vas and affects the globus minor and is secondary to infection of urethra, prostate and seminal vesicles. Blood-borne infections affects the globus major of testis first. Clinical features. ill shivering, aches all over, fever, dysuria, etc. Later, an ache in the groin, increase in the temperature, followed by severe pain and swelling of testes. The scrotal wall become red, edematous and shiny. The epididymis may become adherent to the scrotal skin and may soften and later discharge. Scaling of scrotal skin herald the resolution. Acute epididymitis caused by Escherichia coli, Streptococcus, Staphylococcus, Pneumococcus is a common entity. If there is no infection of urinary tract, it must be the blood-borne infection. Instrumental acute epididymitis followed by urethral instrumentation. Epididymitis complicating non-gonococcal urethritis. It is frequent and if not treated early may lead to suppuration. Acute gonococcal epididymitis usually commences during the second or third week of gonococcal posterior urethritis, usually unilateral. When epididymitis starts, the urethral discharge lessens and pain starts in the testes, followed by cessation of urethral discharge and the urine becomes hazy with pus cells. Temperature rises and patient becomes sick. On third day, the skin of scrotum becomes red adhered to the globus minor. If gonococcus is the sole organism, suppuration does not occur. After 5th day, the symptoms start to abate and by the 10th day condition subsides. Induration of the globus minor may persist for months. Persistent vesicle may cause recurrent epididymitis, may be there. Epididymitis from retrograde passage of urine. Epididymitis can develop by unusual exertion when the bladder is full, causing the urine to be forced along the vas deferens. The degree of inflammation, the presence of infection of urine or prostate of seminal vesicle. Acute tuberculous epididymitis. When the vas deferens is thick and the response to the treatment is less, tuberculous infection is suspected. Acute epididymo-orchitis of mumps. As parotid inflammation is waning, it may be started. The testis in male usually be right, becomes swollen and painful, or vice versa. Resolution or fibrosis usually occurs. Rarely atrophy may follow. Treatment. A small incision is made into the tunica vaginalis and drainage done. If undertaken early, atrophy and pain may be prevented. In infants, epididymo-orchitis of mumps can occur without parotitis. Epididymo-orchitis in Brownholm's disease. The infection occurs as an epidemic. Testicle swells in second week of infection and of undetermined etiology. Epididymo-orchitis due to virus of lymphogranuloma venereum. The infection is bilateral and is followed by abscess formation. There is massive inguinal gland swelling. Confirmation is done by Fry intradermal test. Epididymo-orchitis due to brucellosis, undulant abortus or Malta fever. The disease is started with the epididymo-orchitis. It is confirmed by agglutination test, skin test and culture of urine and blood. Acute postoperative epididymitis. After prostatectomy operation, it may occur as a complication. It is practically abolished by prophylactic division of vasa differentia. Treatment: bed rest. Absolute bed rest is necessary till the symptoms subside. Antibiotic. A suitable antibiotic is given and a culture is performed. The scrotum is supported on a sling formed by broad adhesive plaster attached across the thighs. On this sling, a nest of cotton wool is placed and the inflamed organ is placed over it, and cooling lotions are applied. The urine is rendered alkaline and a high fluid intake is necessary. Antibiotic is continued for 2 weeks or till the inflammation is subsided. If suppuration occurs, drainage is necessary. Atrophy of the testis may follow as sequelae in any case of epididymo-orchitis. Chronic epididymo-orchitis. Most of the chronic cases are of tuberculosis, and disease starts insidiously. Bloodborne infection commences in globus major. Infection of globus minor first indicates that the infection is retrograde along the vas deferens from an infected seminal vesicle. Clinical features: a slight ache or a trivial injury calls the patient's attention to the swelling of testis. Discrete indurated tender nodule in the globus minor, rarely in globus major. As the disease progresses, other nodules appear and whole epididymis is involved and is felt as a firm, craggy, painless mass situated behind the testis, which feels normal. Rarely a lax secondary hydrocele may be present. When the testis is anteverted, these changes are found in front of the testis. The vas on the affected side sometimes is beaded due to submucous tubercles. Rectal examination reveals a thickened, irregular, indurated seminal vesicle of corresponding site, and sometimes contralateral vesicle as well. The prostate in advanced cases contain one or more discrete nodules. Rare cases may present with cold abscess in lower posterior aspect of the scrotum, or a discharging sinus which is healed and recurred several times. If an unattended after a few months, the contralateral epididymis is also diseased, the body of the testis is not involved. In few cases there is either active tuberculosis in renal tract or evidence of previous disease. In the rest, patient is healthy. Investigation. In all cases, the urine is examined for tubercle bacilli. Pyelograph should be undertaken. Chest X-ray is taken for evidence of the disease. Treatment. If tuberculous epididymitis is secondary, the primary lesion should receive priority. The epididymitis will resolve during the treatment. When the renal tuberculosis is present, the renal lesion is treated with streptomycin, PAS and INAH. If there is no resolution within 2 months, epidydymectomy or orchiectomy is advisable. In the absence of evidence of active tuberculosis elsewhere, a further 3 months course of suitable anti-tuberculous drug started. Care of the patient in a sanatorium is good for improvement. Chronic non-tuberculous epididymitis. It either follows an acute attack or is chronic from commencement. The condition is difficult to distinguish from tuberculosis, but it is larger and smooth. It is necessary to exclude the urethral stricture. Treatment. In most cases, associated posterior urethritis, vasculitis, or prostatitis must be eradicated. If condition fails to resolve for 8 weeks of conservative treatment and antibiotic therapy, epididymostomy should be performed. Epididymectomy. Before surgery, permission for orchiectomy should be obtained as it is impossible to determine whether the body of the testis is implicated before the organ is displayed. Procedure. An incision is made from the external inguinal ring to below the testis. If a sinus is present or skin is adherent to the epididymis, the affected skin is included in an ellipse. The testis is withdrawn and the tunica vaginalis is opened. Starting from the globus minor, epididymis is separated from the body of testis by blunt dissection, aided by diathermy needle. As the globus major is approached, great care is exercised. The vascular pedicle entering the testis does so between the upper pole of the testis and globus major, but it is possible to separate the globus major from the testis without injuring the spermatic vessel. The testis with its vessels intact is wrapped in a swab while the vas still attached to the epididymis is separated from the spermatic cord as far as the external inguinal ring. The vas is then divided between hemostats near the epididymis, which is removed. The tip of the hemostat containing the proximal end of the vas is thrust beneath the skin of the inguinal region in an upward and outward direction for about an inch. A small nick is made in the skin over the tip of the hemostat, and the latter together with the vas is pushed through. The end of the vas is grasped in a second hemostat and the redundant vas is drawn onto the surface. This small incision is closed with two sutures, one of which is passed through the outer coat of the vas. The protruding part of the vas is allowed to separate at the skin level, and it shrivels and separates in about 7 days. In this way, the infection of the scrotal wound from the lumen of the vas is prevented. The swab covering the testis is removed, and any bleeding vessels are ligated or controlled by the diathermy coagulation. If hemostasis is perfect, the wound is closed without drainage. Orchiectomy. It is performed when the body of the testis is involved. It is advisable to deal with the vas as has been for epidydymectomy. Syphilitic orchitis. The disease attacks the body of the testis, and like other late manifestations of the disease, all three varieties have become uncommon. Interstitial fibrosis is least so. Bilateral orchitis is found in congenital syphilis. Interstitial fibrosis, it is bilateral, symptomless, and leads to gradual destruction of the seminiferous tubules. The testes are not enlarged. They are firmer than normal, and there is a gradual loss of testicular sensation. In bisecting the testis irregularly, distributed streaks of fibrosis are seen traversing the parenchyma, gamma. This is always unilateral, enlarges slowly and without pain. At this stage, it is odd, testicular sensation is lost, and have a secondary hydrocephalus. Later, there is softening anteriorly, and the skin of the scrotum becomes inflamed, and gummatous ulcer forms. If the response to treatment is not rapid, orchiectomy is performed. then risk the possibility of overlooking a neoplasm. With purely coincidental positive serological tests. Leprous orchitis. Male lepers have testicular atrophy due to fibrosis engendered by the direct action of the Mycobacterium leprae, and in some of these so affected, the orchitis is associated with the gynecomastia. That's all about the epididymitis, and in the next video I will discuss about some other disease. Thank you.